let's do this. We're recording. We're live, people. Okay. So, this last portion of this chapter is really kind of interesting in regards to the body's systems. I know I briefly talked about it in chapter 2 about when we talk about acids and bases and how there's a buffering system in our body, and then we talk about how to neutralize an acid and a base. So we're going to focus more on the buffering system here. But there's a couple of things that I want to talk to you about, especially when we're talking about this guy right here, volatile acids. And in our body, all right, one of the volatile acids is carbonic acid, okay, derived from respiratory gases of carbon dioxide and from water, okay? And so it doesn't last very long. So a couple of the things that you need to understand is, as we're sitting here right now, we are all at rest, okay? So you have to understand that the amount of carbon dioxide that your cells are producing right now is pretty much going to be the same amount while at rest as you're exhaling, okay? So it's like a one in, one out kind of thing, all right? So as one molecule of carbon dioxide is getting dumped into your blood, it's going to circulate to the lungs, and then it's going to get exhaled out of your lungs, all right? Now, at rest. Now, as we know, when we're exercising, all right, several things are going to change physiologically. Obviously, we're going to elevate our carbon dioxide levels, all right, because of cellular metabolism will increase more waste products, all right? Hydrogen ions are going to increase because, again, especially if we're engaging in, anaerobic respiration, okay, we're going to have more acids produced in our body. All right, and then obviously oxygen levels will be depleted, okay? All right, well, hopefully not for a long period of time. We'll have certain respiratory compensatory changes that we learned about when we talked about respiration, all right, that will occur to compensate for that, all right? But all of these are going to be monitored by our friends, the chemoreceptors, all right? And they are going to monitor these chemical levels in our tissues, in our blood, okay? And one of the most important, all right, molecules that, I'm sorry, y'all, that should have been shut off. I don't know why my daughter's FaceTiming. Oh, I know why she's FaceTiming me. She wants to show me her new karate uniform. So, did I ever tell you what she says, why she takes karate? Oh, I never told you that? She says the reason why she takes karate is to become a better bully. I was like, that's awesome. Wow. Yes, I know. I've raised her rights. And then she has 3 principles when it comes to karate. All right? Strike hard, strike first, no mercy. So these are all, that's from the Karate Kid, by the way. All right. So big scenario here when your body is undergoing these metabolic functions here, all right? And as we start to increase, all right, in our metabolism, keep in mind, we learned this when we were talking about the respiratory system. Carbon dioxide is the most important variable, all right, in determining some of the physiological compensation changes that occur in the depth of breathing and the rate of breathing, all right? So carbon dioxide levels play a large role, and then hydrogen ion concentration plays a large role also. Oxygen doesn't play as big a role as you would think. Okay, so it's really going to be carbon dioxide, right? So when we deal with carbon dioxide, we can't help but deal with carbonic acid, okay? Important concept here for going forward here. The levels of carbonic acid depend on the levels of carbon dioxide, okay? So if we increase carbon dioxide, we're going to increase carbonic acid. We decrease carbon dioxide, we're going to decrease carbonic acid, and vice versa. All right? If we decrease the carbonic acid, we're going to decrease the carbon dioxide levels. All right? So keep in mind that these are dependent. The levels of the carbonic acid are volatile acid. All right? And if I can find that equation, I'm telling you, folks, we're going to be talking a lot about this equation today. Whoops. All right, here's carbonic acid. Okay, so this whole equation here, carbon dioxide plus water with carbonic anhydrase enzyme will give us carbonic acid. And then what that will happen, that carbonic anhydrase will then yield us hydrogen ion and bicarbonate. and vice versa. You notice these arrows go both ways, so this means that this equation can swing in either or direction. Okay, either or direction, depending on what physiological occurrence is happening here. All right, that's why I need you to understand, because as we go forward, we're going to be discussing some of these things here. Okay. So for the most part, carbon dioxide and carbonic acid, all right, do not have daily fluctuations. Okay. So they're not going to really affect our acid-base balance, our pH levels. All right, we're going to talk about what is going to affect those. All right, so pretty much in picture form, this is just basically showing us, here are our cells undergoing their fun cellular metabolism, producing cellular wastes. Here's our respiratory waste gas being produced by the cell, diffusing into the bloodstream, traveling through the lungs, and then from the lungs, it's being exhaled. All right, so that's what we're going to see here. All right, so 1 molecule of carbon dioxide in normal resting people, all right, they will exhale that 1 molecule of carbon dioxide as they take a breath out. Okay, so keep that in mind. That's why, if you noticed here, all right, when we're talking about the partial pressure, all right, of carbon dioxide in our circulation, it's usually between 35 to 45 millimeters of mercury. Okay, not a lot of fluctuation going on in that. All right, so we're going to see it relatively steady. Now we're going to be talking about what's going to happen now when we change, all right, some of these levels in our circulation. So chemical buffers. Okay, there's 2 types of buffers that we're going to be discussing. All right, we have chemical buffers and then physiologic buffers. All right, but you need to understand that buffers prevent changes in pH. All right, remember, we want to keep our pH at 7.4 or between the range of 7.35 to 7.45. All right, so it's these buffers that prevent those changes. It helps to keep it in that range. And the nice thing is that these buffers act almost immediately, within minutes. Okay, within minutes. All right, so some of these molecules that we're going to be discussing are going to bind, but also release hydrogen ions. And it can happen in a blink of an eye, depending on what's going on. If we're in an acidic environment or if we're in an alkaline environment. All right, so chemical buffers are going to be weak bases and weak acids, because both of those can bind and release, all right, hydrogen ions. Okay, a weak acid, all right, is going to release the hydrogen. Remember, an acid is what we call a proton donor. Okay, and I know I keep referring to this as a hydrogen ion. And I do so because when I call it a proton, sometimes that confuses some folks because they think of the subatomic particle, the proton in an atom. All right? So acids are proton donors, which means they'll release the hydrogen ion, and bases, think of them as a sponge, all right, for hydrogen ions. They'll soak them up, so they'll bind hydrogen ions here. Okay? So some of the characteristics of buffers are they're temporary and they're limited. We'll talk about what happens in situations, all right, where their limitations have been exceeded, okay? And then we got to pull in the big guns here, the physiologic buffering systems, okay? Physiologic buffering systems are going to be those systems that are actually going to get rid of, all right, excess acids and bases, okay? So the chemical buffers, that's a temporary fix. All right, whereas our physiological buffers, that's going to be more of a larger scale, all right, but those are the big guns there, okay, because they're going to eliminate things. Okay, so when we talk about our chemical buffering systems, there's 3, and you've had some, not experience, but some exposure to these 3, all right, and you didn't even know it. All right, so we got proteins, phosphates, and bicarbonate. We talked about bicarbonate when we were talking about the chloride ion shift, all right, and then we also talked about bicarbonate when we were discussing the urinary system and how bicarbonate is filtered and then how it gets quote unquote replaced, all right, and put back into our bloodstream. Okay, if you're not sure what I'm talking about, watch the previous video. okay, that I recorded over the weekend. All right, so our proteins are going to be found both in the cells and in the blood, all right, whereas the phosphates are only inside the cells. And then, of course, bicarbonate is only outside the cells. Okay, so you have at least 2 chemical buffering systems in both compartments, in the ICF and in the ECF. Okay, so 2 are going to be located. So let's start off with number 1. All right, our protein system here. This makes up the majority, 75% of the chemical buffering systems in your body fluid compartments, in the ICF and in the ECF. Okay, so we discussed some of these plasma proteins before. All right, we were talking about the foreign protein elements of your blood here. All right, a significant amount of those proteins are going to be produced by the liver. Hemoglobin was one of those proteins. All right. As you know, yes, hemoglobin does bind oxygen, all right, but it also is going to bind carbon dioxide, and it's going to cause, all right, the transport of the carbon dioxide molecule in the form, all right, of this buffering. We create the bicarbonate there, okay? So the amine group, and again, this is going back to 210, all right? But as you know, proteins are made up of amino acids. It's a chain of amino acids. It's got to be 200 or more amino acids strung together. Right? At one end of the protein, all right, you have an amine group, and that's going to be your nitrogen group. Whoops. It's going to be your nitrogen group with the hydrogen ions, the hydrogen molecules bound onto it. Okay, and then we've got the carboxylic acid group. All right, and that's going to be at the other end. Okay, so one end will act as a weak base to buffer an acid. The other end can act as a weak acid to buffer a base. Okay, that's the nice thing about proteins. All right, and this is one of the characteristics, especially the carboxylic acid end. All right, or what they call the C terminal. That's the end that is going to give the atom, or not the atom, excuse me, the molecule, the protein molecule, a negative charge. That's what kind of keeps it trapped inside the cells here, okay? All right, the phosphate buffering system, this is going to be found exclusively inside the cell and the ICF, okay? Now, again, we're going to deal with, it's perfect to have the phosphate, all right, molecule inside the cell, because it's these cells, when they're undergoing their metabolic processes, that are going to be producing, all right, these metabolic acids. Lactic acid is an example of that, okay? And so what we'll see is, all right, with these buffers, all right, keep in mind, buffers are going to cause, well, I'm going to show you down here. Strong acids will be reduced to produce weak acids, and that's a result of the buffering system. All right, especially keep in mind when we're dealing with acids. Okay, we talked about when pH levels drop, several changes occur. You're going to be messing around with enzymes. You're going to be causing denaturation of proteins, when proteins will just start to break apart. All right. And we see all the valuable functions that proteins have, all right? So it's really important, especially when we're dealing with low pH levels, all right, that we take a strong acid, buffer it, and yield ourselves a weak acid, so we can prevent those pH level changes from occurring significantly, where it starts to cause the malfunctioning of certain macromolecules, all right, inside of our cellular structure, okay? So when we're dealing with our buffering system, the hydrogen phosphate molecule, all right, is going to act as a weak base. All right, the dihydrogen phosphate molecule will act as our weak acid. So basically, think of it like this. The phosphate molecule is going to reduce a strong acid to a weak acid, and a strong base to a weak base. Again, that's going to help to prevent large changes in our pH scale, all right, inside the cell. All right, we want to maintain that certain range there. All right, that is what homeostasis is about. All right, balance, equilibrium, all right, healthy functioning. That's what we're trying to do. All right, then our final chemical buffer is going to be the bicarbonate. And we've already talked about the bicarbonate a little bit here. But here's the thing. It is the most crucial form of chemical buffering system in the ECF, the blood plasma. All right? And in the interstitial fluid. But we talk more about it in the blood plasma. And it's the same type of scenario here. When we're dealing with the bicarbonate buffering system, all right, bicarbonate, all right, is going to act as a weak base, and then carbonic acid, all right, will act as a weak acid. Doing the same thing. We're going to reduce a strong acid to a weak acid. We're going to reduce a strong base into a weak base, all right? But it's this bicarbonate system that's going to help us to do that, to buffer that, all right? So think of it in the form of when we're talking about bases, okay? They're going to go around and act as a sponge and soak up those protons, those hydrogen ions, right, and help to buffer those. And we're going to go through some of this, all right? And then with anything I talked about, there's a limitation to our buffering system, and we call that the buffering capacity, all right? That's that limitation, all right, in regards to the amount of acid or base that the actual chemical buffering systems can handle, okay? When it exceeds that, that's when we start to get where we have to deal with our physiological buffering systems. All right, we're going to have to start eliminating, all right, some bases or start eliminating some acid, okay? And we're going to talk about those systems here now. Any questions about what I've just mentioned? All right, so kind of like a quick review, a little bit of an overall, all right? But now I want to talk about acid bases or acid-base imbalances, okay? So what happens now, our chemical buffering system is just not cutting it, all right? We're now starting to swing in one direction on our pH scale or the another, okay? So remember, here is our range right here, 7.35 to 7.45, all right? Looking for that 7.4 value right there. All right, so this is review. Acidosis is going to be when the arterial blood is below that 7.35. All right, alkalosis is when the arterial blood pH is going to be above the 7.45. We're outside of our ranges there, okay? So now we've exceeded the buffering capacity. Got a problem, okay? We have issues, all right, with the levels of our hydrogen ions, okay? Is there too much? Is there too little, okay? Our pH is now swung outside of our normal range here. Okay, so now we have to figure out, we have to elicit some processes, all right, in our body systems to handle that swing outside of that normal range, okay? So our response when we're going to kick in our physiological buffering systems, we call that compensation. Aptly put, okay? So when these systems kick in, these physiological systems, which we're about to talk about, all right, when they're kicking in and doing their thing, they're compensating for the problem, okay? So we call that compensation, all right? When they're not effective, then we call it uncompensated, okay? So if you're reading a report and they're talking about someone's pH values, all right, and they're using these terms, compensated and uncompensated, if you see uncompensated, then you know that there's a good chance, depending on if it's metabolic acidosis or respiratory alkalosis or whatever, and it's uncompensated, then you're going to start to think, hey, maybe this person has got some issues with their kidneys, or maybe this person has got some issues with their respiratory system, their lungs, all right? Something's going on, or there's a circulatory issue going on, all right? So we're going to be discussing some of these, okay? All right, so let's talk about these acid-base disturbances here, okay? So what we're going to see when we have an acid-base imbalance, we will have a persistent, all right? It's not going to be an intermittent. It's not going to be just one random thing. This is a persistent change in the pH, all right, of that individual, okay? So if it's left unchecked, this person could potentially die or have some significant damage to certain, especially when we're dealing with the nervous system, and when you're dealing with the central nervous system, you can get that person to go into coma, all right, and possibly even death, all right? So we don't want to mess around with that, okay? So when we talk about what had caused this issue, we're talking about the types of disturbances, all right? So the primary disturbance, all right, cause is either going to be respiratory lungs, metabolic kidneys. Okay? So when we're talking about the types of disturbances, it's either going to be involving the lungs or the kidneys, all right? And it's either going to be, when we're discussing the change in pH, it's either going to be acidic or alkaline. So we have 4 categories. All right, respiratory acidosis, respiratory alkalosis, metabolic acidosis, metabolic alkalosis. All right, these will be our acid-based disturbances. So when you read these titles here, all right, respiratory acidosis. Okay, so I look at that, I'm thinking, all right, lungs, right there. Okay, that's going to be the primary disturbance, is the lungs. All right, and if it's acidosis, then we're dealing with a low pH. And if I have low pH, all right, I'm acidic, that means I have a high concentration of hydrogen ions. Okay? So let's discuss, since I started with respiratory acidosis, let's talk about it, because this is the most common one. Okay? So here's what's going on. Your lungs are having a problem with you exhaling carbon dioxide. Okay? So that's a problem, because if I can't exhale carbon dioxide, then what I'll see is I'll increase my carbon dioxide levels in my blood above that 45 millimeters of mercury. Right? I hate to do this, but I'm going to go back. Whoops, wrong way. I want to show you this. Write this down if you haven't already. This equation, a lot of what I'm going to be discussing is going to involve this equation here. CO2 plus H2O, so carbon dioxide and water, all right, are going to yield us carbonic acid, which is a weak acid, part of our chemical buffering system. All right, that then with carbonic anhydrase will yield us hydrogen ions and bicarbonate. Okay, so this again, and we're going to swing, all right, this equation either or. Okay, so in this situation, when we're looking at our respiratory acidosis, right? We cannot exhale, all right, carbon dioxide. So it starts to build up in our lungs. So we're starting to get increased levels of carbon dioxide buildup there, all right? Which will then, when it combines with water, it's going to yield us carbonic acid. And we're going to start to see increased levels of those guys there, all right? Let me come back to my page. Where am I? Here we are. Okay, so we start to see the partial pressure of our carbon dioxide in the arterial blood increase. Okay, and so therefore, as this increases, we will get an increase in our hydrogen ions. You saw in that equation there, all right, why that's happening, all right? So this is bad for babies, okay, for a number of reasons. Okay, so I mean, the obvious reason is their lung capacity. Okay, they cannot handle, all right, the demands now because they have that lower residual volume, and that's the amount of air remaining in the lungs, all right, after a deep exhale there. Okay, so there's going to be ways they're going to try to compensate. I'm going to just start off here with first the disturbances, then I'll explain to you how we fix the disturbances. Okay, so here's our situation. Our patient, this baby, cannot breathe off the carbon dioxide because there's something wrong with the lung function of that child. And so we're starting to see an increased amount of carbon dioxide building up in the arterial blood. As a result, we're swinging our equation, all right? I'm going to come right back to this slide here. Here's our picture, all right? So we're going to swing our equation. This person is unable to exhale carbon dioxide, right? And so we increase our carbon dioxide levels here in the blood, and it pushes our equation, that CO2, all right, and water, all right, it's going to swing it to this side here, producing more hydrogen ions, all right, but also producing our bicarbonate. But because we're producing more hydrogen ions, if we have a lot of hydrogen ions, what's our pH value going to be, high or low? Low, inverse relationship, inverse. One goes high, the other goes low. Okay, the higher the hydrogen ion concentration, the lower the pH value, which means it's acidic. It's acidic. Okay, So that's what we're seeing here. That's our problem. Where am I? I'm on the right one. Okay. All right. So what are some of the causes? Okay. Hypoventilation. Remember, what stimulates our breathing rate primarily is going to be the levels of carbon dioxide in your blood, all right, and in the cerebral spinal fluid, okay, and the hydrogen ion concentration levels before we get to oxygen. So this person is breathing too slow and too shallow. So they're not able to exhale that carbon dioxide. Something's wrong maybe with the respiratory center. Maybe they got hit in the head, okay, and it damaged their pons, it damaged the medulla oblongata. They're having some issues there, all right? Or maybe they got meningitis, okay? And that meningitis, that infection there is affecting that area there, all right? Or maybe they suffered a blow, all right, to the phrenic nerve. Oh, God forbid. Phrenic nerve is the nerve that innervates the diaphragm, all right? So they're going to have a big problem with the breathing aspect there, all right? Point being is they're not breathing deep enough and they're not breathing fast enough. So they can't breathe off that extra carbon dioxide. So where does it stay? In the blood, okay? So here's another problem they could be having. Decreased airflow, right? Here's me, asthma, okay? Soft, the smooth muscle in my bronchioles becomes inflamed, causes bronchoconstriction. The airways become smaller. Increases the resistance for airflow, right? Much more difficult to get air moving through those pipelines. Bronchitis, all right? Folks that smoke, okay? You see a lot of bronchitis. I see, well, around here in the wintertime and around seasonal periods of time, fall, early spring, okay, is a high susceptible period of time to get bronchitis, all right? Or say actually they're eating something and they accidentally inhale when they're eating when they shouldn't be, and something goes down the trachea and into one of the bronchioles, and we have some airway obstruction. Finally, we're dealing with gas exchange issues, okay? Fibrosis, it's not listed up here, but they get that thickening of that respiratory membrane, okay, due to scar tissue, for example. Emphysema, same thing. We see that thickening of that respiratory membrane there, or pneumonia, all right, because there's some sort of issue going on, all right, that's affecting our exchange site for respiratory gases. And that's what we're going to see here. So these are some of the possible causes. Again, respiratory acidosis is the most common acid-based disturbance. All right, respiratory alkalosis, opposite now, okay, opposite. So now we have a situation, all right, in which this person's partial pressure for carbon dioxide falls below 35 millimeters of mercury. Now, all right, this is a person that's freaking out. All right, they're suffering an anxiety attack. This is one of the things you worry about when somebody is suffering from an anxiety attack. A friend of mine in high school, I wasn't there, so I'm the good person in this story, all right, decided to try marijuana for the first time and had such severe anxiety to it that he was literally hyperventilating, and they had to take him to the hospital because he fell into respiratory alkalosis, all right? And he was freaking out, and he kept screaming, "Take me to the hospital, take me to the hospital." So they finally did, all right? And it's because, all right, he was having issues, all right, with, he kept exhaling and breathing out that carbon dioxide, and now we see decreased levels of carbon dioxide, which drops, all right, remember that equation right here, okay? So in this situation, as they keep breathing out carbon dioxide because they're hyperventilating, their carbon dioxide levels decrease. And as such, the hydrogen ion concentration levels will decrease. So this equation will swing more in the right to left direction. All right, we're going to take our hydrogen ions with the bicarbonate, make carbonic acid, and then try to increase our carbon dioxide levels here. All right, the problem is we keep breathing it off. So our carbon dioxide levels are dropping sharply, but this equation is still going, this reaction is still going to occur, all right, in our circulatory system to try to increase our carbon dioxide levels. So at the same time as we're decreasing the hydrogen ion concentration levels, we're increasing pH, making our blood more basic or alkaline, okay? Hypoxia is another scenario here, all right, this is what you will see. All right, first of all, folks that are climbing at high altitudes. I've never been on the West Coast at high altitudes, all right, but I know it's common. Like if you go to Denver, Colorado, I think that's Mile High Stadium. So a mile is what, 6,000 feet close to, I think it's about 5,000 something, whatever. So at those places there, all right, especially in the Rockies, Andes, where am I thinking? Oh, Himalayas, all right, the Himalayan mountains, all right. So altitude, you're going to see decreased oxygen here, all right, and that will cause an offset in your ventilation rate, okay? And then aspirin overdose. That's why it's very, very important, all right, because not just because of this, but you don't give aspirin to young children under the age of 6, all right, which is kind of not funny to me, but my mom used to give us crushed aspirin in Welch's grape jelly if we had any sorts of pain. And I guarantee you that I was taking aspirin well before I was 6 years old, because I have very big memories of that. So only medication. But not only do you have to worry about aspirin overdose, but has anyone ever heard of Ray's syndrome? It's a phenomenon in which with aspirin in young children, I can't remember. You can get a skin outbreak and something else can happen, but I can't remember the other symptoms there. All right, so now we're done with the lungs. Let's talk about our kidneys, all right, because we are going to talk about metabolic, okay? So now, in this scenario here, when we're dealing with metabolic acidosis, all right, we are going to have an elevation again in our hydrogen ion concentration levels, okay, which will therefore decrease the pH, which will make us acidic, okay? All right, so we'll see a loss of bicarbonate. That is going to be our buffer, all right, for our base there, okay? But most of the time, we will see an increase in the hydrogen ion concentrations, all right? Again, we're going to see this more commonly in infants, all right? Well, one, because their urinary system, okay, the kidneys aren't as apt as ours, okay? So, and plus, what are babies doing? Growing, all right? Their cells are constantly undergoing metabolism. So for their weight ratio versus our weight ratio, all right, they're going to produce significantly larger amounts of acidic metabolic wastes, all right, as a result of all the physiological processes that they're undergoing, okay? So it's more common to see this, all right, metabolic acidosis, all right, in infants, all right, than you or I, okay? Unless there's some issues like if we're a diabetic, right? And I've talked about this before, ketoacidosis, right? Ketoacidosis is going to be when you undergo fat metabolism. Well, guess what? Type 1 diabetics, all right, since they're not producing insulin, they can't undergo, all right, glycolysis as well. So those patients rely more on fat metabolism for their energy, okay? So they'll get a larger number of ketoacidosis metabolic products from their metabolism, okay? Lactic acid from glycolysis if you're undergoing, all right, anaerobic respiration, okay? If you're undergoing aerobic respiration, then you're good because you won't shunt, all right, that glucose into lactic acid, all right? You'll shunt it into pyruvate, and then pyruvate along with oxygen can enter into the mitochondria so you can break down, all right, the pyruvate and the acetyl-CoA into our ATP there, okay? All right, questions so far? Good, so, okay. All right, oh, and then not to forget problems with the kidney, renal dysfunction, and we discussed this before, was it last week? All right, when we talk about folks with severe diarrhea, all right, because of severe diarrhea, you can deplete your bicarbonate levels significantly, all right, because of the malabsorption that occurs, all right, as a result of diarrhea, all right, and so those folks are, instead of being able to absorb bicarbonate across the digestive tract, they're going to eliminate it, all right, through the digestive tract there, out through the rectum and the anus there, therefore depleting the bicarbonate, right? Remember, all right, when we get to metabolic acidosis, it's going to be one of two things. It's either going to be a loss of bicarbonate or a gain of hydrogen ions. All right, then finally, our last acid-base disturbance is going to be metabolic alkalosis, okay? So in this scenario, just switch it. We are going to have a loss of hydrogen ions or a gain or increase of bicarbonate. Okay? So, folks, some of the common causes. This was my son last night. Okay? Vomiting. And when you vomit, all right, you are emptying the contents of your stomach. Well, one of those contents is going to be hydrochloric acid, all right, HCl. Okay? So HCl can be broken down into hydrogen ions and a chloride ion. Okay? So he is losing his hydrogen ions when he is vomiting, therefore he's increasing, all right, his pH. All right? Antacids, talked about this before. All right? Constantly taking something that is going to neutralize your stomach acid. All right? And these are people that, when I say that they chew on antacids, this is the patient that when they come in, all right, and they empty out their pockets, they're the person that's carrying Tums with them. All right? And it's frequent. You know, it's not just a one-time thing. That's what they carry. Just like you carry your car keys with you and your cell phone with you, this person carries Tums with them all the time. Because, oh, I got heartburn. No problem. I'll just keep popping Tums. Hey, congratulations. Guess what you've just done to yourself? Welcome to metabolic alkalosis. All right? Because you and your Tums are neutralizing your stomach acid. And I won't even get into all the other stuff that goes down the road, because when you're neutralizing your hydrochloric acid in your stomach, guess what? You're impeding your chemical digestion of numerous macromolecules, all right? And that's going to cause problems with malnutrition, okay, and other issues, okay? And then also, all right, when we talk about issues with the kidneys here, all right, folks that are constantly on diuretics, right? Diuretics make you pee all the time, okay? But what will happen is when you're on diuretics, all right, because of the exchange pump there in the kidneys, all right, you'll lose acids, all right? And so therefore, if you're losing acids, all right, you're going to be increasing your pH, okay? Almost done. I know you guys love this chapter. I love this chapter. I think I say that about every chapter, though. If I said that about every chapter almost, I know. All right, so let's talk about lactic acidosis and ketoacidosis. Lactic acidosis, all right, obviously, if you're suffering from lactic acidosis, you're going to have significantly large amounts of lactic acid. And that's because either you're a freak of nature that is exercising extremely, all right, and while you're exercising, you're not getting in enough oxygen. All right. Remember when we went over chapter 2, 327, all right, we talked about metabolic pathways. In order for glucose to yield that 32 ATP, okay, it needs oxygen. Because without it, for every 1 molecule of glucose, you're only going to get 2 ATP. Okay? But if you got if you got oxygen, then that pyruvate, well, let me say this, without oxygen, you're going to wind up with lactic acid. With oxygen, all right, we are going to convert that pyruvate into acetyl-CoA. That acetyl-CoA will jump into the TCA cycle inside the mitochondria, and then we'll be able to get our 32 ATP. All right, ketoacidosis. Again, when we're dealing, large amounts of keto acids from our fat metabolism here. And you heard me talking about that before with the type 1 diabetic. All right, they will primarily be using, all right, ketoacidosis. There's a difference because a lot of folks confuse ketoacidosis with the keto diet. If you're familiar with the keto diet, all right, that's a diet that's very low in carbohydrates. So you're forcing your body to create what we call ketone bodies. And your brain loves ketone bodies when glucose is not around. I mean, it doesn't want it. It prefers glucose, all right? But if there's no glucose around, it will utilize the ketone bodies, right? Ketone bodies can be yielded from protein metabolism and whatnot, and will form. It's like an energy source that you can use in a pinch. It's not ideal. You don't want to be using it all the time. Well, when we talk about ketoacidosis, all right, because type 1 diabetic doesn't have insulin to help with glycolysis, all right, whatnot, now we have to use fat instead, okay? And so as a result of that, we're going to wind up with ketoacids.
My dad went on the keto diet last year and he lost over 115 pounds.
Yeah, let me tell you something. The keto diet is impressive. It's not for everybody because I know several people. It's just like Weight Watchers is not for everybody. What's the other one? Nutrisystem. There's all these things that are out there right now. And really what it is you need time. And what I mean by that is you need to figure out what your body responds to best. I mean, your body's always in survival mode. Here's the thing. So when you start to slow down on the amount of food that you're putting in, your body's like cool with it for the first 24, 48 hours. It's like, whoa, 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 what's going on here? I got to kick into survival mode. Who knows when I'm going to be able to eat next? So what does it do? A lot of times it'll start to slow the metabolism down. That's why folks will complain about sometimes when they're trying to lose weight, they'll start to lose weight, and then after a while they start to plateau because the body adjusts. That's all homeostasis. It's adapting. And so you just have to kind of tweak things. So whenever I talk to any of my patients about diets and whatnot, I said be patient. If you're going to go into a diet, you better prepare yourself for a year to 2 years and see it through. And it might not be the right one for you. Well, no problem. We'll figure it out. We'll figure out what's right for you. All right. I want to finish up with talking to you about this awesome word, compensation. Okay? Compensation. So now we're going to talk about how, all right, these organs that we just talked about for the primary disturbances, the lungs and the kidneys, what type of adjustments they're going to make to the changes in your pH. Okay? So let's look at the first one here. All right, you have elevated levels of hydrogen ion concentration in your blood. Okay? So now again, there's numerous causes for this. Let's not include kidneys, because guess what? If there's renal dysfunction, then most likely renal compensation won't work worth a damn. Okay? So we have to exclude kidneys for this. So it could be all sorts of things. Maybe you're just working out extremely hard. You're starting to get a buildup of lactic acid levels. All right? Some stuff is happening here. All right? So we're going to deal with our type A intercalated cells. So real simple. Here's what's going to happen. Your blood concentration of hydrogen ions increases. So you don't even have to read the book to figure this out. What do we want to do? We want to get rid of hydrogen ions. So the intercalated cells, the type A, are going to excrete hydrogen ions and resorb, this should be in quotation marks, all right, resorb bicarbonate. Okay? That's basically that simple. Okay? Get rid of the hydrogen ions because it's the hydrogen ions that are going to decrease the pH, which is going to make the blood more acidic. Okay? So we do that, we increase more bicarbonate because now the bicarbonate can get dumped in there to do its buffering thing. All right? So we'll see, all right, in these folks, all right, that have, all right, this renal compensation, this metabolic acidosis, we'll see in their blood works, they'll have elevated levels of bicarbonate in their blood, which makes sense because we want that bicarbonate to float around and suck up any of those free-floating hydrogen ions. All right, because guess what will happen? It'll combine with the hydrogen ion with the help of carbonic anhydrase and form carbonic acid. Okay, from there, then with carbonic anhydrase, that enzyme will then convert carbonic acid into carbon dioxide and water. And there you go. Okay? We'll also see in these folks that the pH of their urine will be lower. Why is that? Why is the pH of the urine low? Why is their urine acidic? That's right, girl. That's right. This is what we're doing. We're getting rid of hydrogen ions. And that's why my PP is going to have a low pH. Okay? Because we're getting rid of it. Okay? Again, not too difficult if you kind of take the time to kind of think some of this stuff through. All right? How about this one? All right? Let's talk about what happens when we have decreased levels of hydrogen ion in our blood. Okay? Now we're going to incorporate a different cell, type B intercalated cells. But same thing, all right? Decreased blood pH, which means I have high did I say decreased blood? Decreased blood hydrogen ion levels, that means I have increased pH. We're dealing with alkalosis. Okay, so if that's the case, then I'm going to resorb hydrogen ions, and I'm going to get rid of bicarbonate. Okay, I'm going to do that, and now what I'll see is, if I do a blood draw on this patient, then I'll see low levels of bicarbonate in the blood. All right, but I will see, if we do a urinalysis on this patient, they're going to have a higher pH. All right, it'll be more basic because, there we go. We're getting rid of our bicarbonate. And that's why our pH is going to be higher. All right, so the renal compensation works pretty well, all right, as long as the kidneys are functioning well. Okay, if we're having kidney dysfunction, we're going to have some other problems. But guess what? That's where this comes into play. Respiratory compensation. Don't forget about the lungs. Kidneys play a primary role. All right, the lungs will help. All right, the lungs will help. Okay, keep in mind, we'll see respiratory compensation when we see metabolic acidosis or alkalosis. Okay. Notice it doesn't say respiratory acidosis or respiratory alkalosis there, but metabolic. That's when we're going to see renal compensation occur. Okay, so here we go. Respiratory rate will increase, and you already know this, when we get increased hydrogen ions present. All right, remember the three things that affect your respiratory rates and the depth of breathing: carbon dioxide levels, hydrogen ion levels, and O2 levels. All right, carbon dioxide and hydrogen ion levels are going to affect respiration and depth of respiration way more than oxygen levels. So we're seeing an increase in hydrogen ion concentration. Okay, so going back to that equation that I keep referring back to, all right, when we see increased levels of the hydrogen ion concentration, all right, what do you think is going to occur? We're going to want to get rid of, all right, carbon dioxide. Okay, so we're going to see more carbon dioxide being breathed out. Okay, so this person will have, all right, faster respiration rate, and they'll be deeper. Okay, and we'll see lower partial pressure of carbon dioxide in the blood. So it could be below 35 millimeters of mercury. All right, now, what happens to the respiration rate when we see decreased hydrogen ion concentration level? We're going to decrease the respiration rate. Okay? And as a result, all right, we'll see less carbon dioxide being breathed out. We'll see higher values in our carbon dioxide in our blood. All right? And again, going back to that equation, I know I've done it. I'm going to do it one more time. I would recommend, I just missed it. There it is. All right, that you understand this. When, all right, if this is increased, we're going to shunt the equation this way. So that will increase our carbon dioxide levels, but then we'll exhale that when we're dealing with, all right, our metabolic acidosis, okay, our breathing rate will increase. Now, we switch that up. If hydrogen ion levels decrease, all right, we'll shunt it this way, all right, and we'll decrease carbon dioxide levels that are being exhaled, all right, because we want to keep it in the blood. So we can actually swing our equation this way so we can increase our hydrogen ion concentration levels, and at the same time we'll increase our bicarbonate. All right, but of course the way to go is going to be renal compensation. All right, respiratory compensation doesn't do as good a job, all right, as renal compensation does. All right, when we're dealing with the physiological buffering systems then. Okay? All right, questions about that? OBKB. All right, finally, done with that. Not that I'm upset. I love